Have you ever found yourself, waking up multiple times a night, dragging yourself to the bathroom? Or maybe feeling like you're straining just to empty your bladder? It's actually a surprisingly common thing.
Yeah.
But maybe one people don't fully grasp the cause of.
Yeah, and these aren't just like small inconveniences, right? They're really classic signs of benign prostatic hyperplasia, BPH, basically an enlarged prostate.
Right.
And this affects millions of men globally, especially as they get older. Think about it. Maybe half of all men over 60 have it. And that number, well, it just keeps climbing pretty dramatically each decade.
Wow. You really highlighted how common these issues are. So what's the thread connecting these things people might not realize? The frequency, the urgency, that annoying dribble, or feeling like you haven't completely emptied, because they can seriously mess with your quality of life.
Oh, absolutely they can. You're right. For many men, lifestyle tweaks or medications are the first steps. But for quite a few, those just, well, they don't cut it, or maybe they can't handle the side effects. And that's when surgical options really come into play, offering, a more definitive kind of solution.
Okay, so our mission today is really to take a deep dive into the evidence. We want to give an overview of the pretty wide range of surgical options out there for BPH.
Yeah, let's break it down.
We'll pull out the key benefits, the risks, the factors you need to think about for each one. The goal is you walk away well-informed, ready to talk things over with your doctor.
And for this deep dive, we've pulled insights from a really in-depth discussion by Dr. Rena Malik. She's a urologist and pelvic surgeon, and also info referencing the 2023 American Urological Association, the AUA, guidelines for BPH treatment.
Great sources. So let's unpack this then. When does surgery actually become a real option for BPH? Is it always like the last resort, or are there specific times it's considered sooner?
It's not always the last resort, no. Though, yeah, it often comes after other treatments haven't quite worked or weren't tolerated well. Generally, surgery is on the table when meds just aren't giving enough relief.
Okay.
But beyond that, there are what we call absolute indications. These are times when surgery isn't just an option. It's often, well, pretty crucial.
Absolute indications. That sounds pretty serious. What are those specific sort of non-negotiable situations?
Yeah, they are serious. They include things like recurrent urinary tract infections, UTIs that are directly linked back to the prostate issue.
Okay.
Or persistent bleeding coming from the prostate itself, kidney problems because urine is backing up, which is obviously not good, or simply being unable to urinate at all without a catheter that's complete urinary retention.
Right.
These are situations where you need to act.
That makes total sense. So, okay, once surgery is on the table, it sounds like there isn't just one best procedure for absolutely everyone. How do you even start figuring out the choices?
Oh, absolutely not. Choosing the right procedure is incredibly personal. There really is no one-size-fits-all solution. It truly depends on a whole host of crucial factors unique to each person.
So what are those crucial considerations then? What should someone be thinking about, talking about with their doctor before making what is, a pretty big decision?
Well, first off, the specific size and the anatomy of your prostate is really key.
Okay.
Not all procedures work well for every prostate size or shape, especially if you have something called a median lobe. That's a part of the prostate that can kind of grow up into the bladder opening.
Ah, right.
Then your overall health, obviously, and how well you can tolerate anesthesia. That's vital.
Sure.
We also look carefully at current medications, especially if you're on blood thinners. That can definitely impact which procedures are safe to even consider.
And what about those quality of life things like sexual side effects? I
Yeah.
imagine that's a major concern for a lot of men.
It's a huge one, absolutely. The impact on sexual function, specifically preserving ejaculation, is a major factor for so many men. And some procedures are, frankly, much better than others on that front. And finally, your personal tolerance for, say, recovery time, and also the perceived risk of maybe needing another procedure down the road. Those are really important conversations to have up front.
Okay, this is great context. Let's dive into the options themselves now. Starting with what are generally called minimally invasive procedures. What does that label typically mean for a patient? The procedure itself, where it's done, and maybe most importantly, recovery and sexual health.
Right. So generally, these are less invasive, as the name suggests. Often they can be done right in the office or as an outpatient procedure.
Okay.
And they're really designed to minimize disruption, especially, as you said, to sexual function. And the first one we can look at is Rezum, which is also called water vapor therapy.
Resin, water vapor therapy. It sounds, I don't know, almost deceptively simple for what seems like a complex problem. How does it actually work?
It does sound simple, but it's actually quite clever. It uses targeted steam water vapor to ablate, which basically means remove or destroy the excess prostate tissue.
Cool.
The scheme causes those prostate cells to die off, and then your body just naturally reabsorbs the treated tissue. So the prostate shrinks over time. It's usually done in the office, maybe with local anesthetic or just light sedation.
So what's the big draw? Why are patients choosing Rezum, and what's recovery typically like?
Well, one of its major pluses is that it generally preserves sexual function pretty well. Very low risk of erectile dysfunction, ED.
That's huge.
It is. Recovery usually involves a temporary worsening of urinary symptoms for maybe 2 weeks or so, just while the swelling goes down. Full improvement can take a few months.
Okay.
As for needing it redone, initial studies showed around 7.5% at 5 years, though, some bigger real-world studies suggest it might be higher, maybe up to 25%. I think the real insight with Rezum is just that unique ability to relieve symptoms while really prioritizing keeping sexual function intact. That makes it a compelling choice for a lot of guys. It's generally best for prostates under 80 grams. Data on larger ones is still kind of coming in.
Okay, so Rezum uses heat, steam, but there's another clever approach that uses a different kind of lift, right, to sort of open things up.
Yeah.
That's Urolift. How does that one work?
Yes, exactly. Urolift places tiny permanent implants to essentially hold the prostate tissue away from the urethra. Think of it like curtain tiebacks, holding curtains open.
Ah, good analogy.
Right. So if your urethra is the narrow hallway, these implants just keep the walls, the prostate tissue, from bulging in and blocking the flow. This one also uses local anesthesia or maybe light sedation.
So where does Urolift really shine? And are there any, common downsides or pitfalls?
Its main advantage is, again, minimal impact on sexual function. No significant issues reported with ejaculation or erectile function. And most men feel improvement in their flow pretty much immediately.
Well, immediate. Okay.
Yeah, that's a big draw. So the key takeaway is that immediate symptom relief with very few sexual side effects. That makes it a strong contender for men prioritizing those things. The main drawback, well, the retreatment rate can be up to 22% within 5 years.
Okay.
And again, generally best for prostates under 80 grams, and like we mentioned, not always ideal for certain prostate shapes, especially if there's a median lobe involved.
Fascinating stuff.
Yeah.
Then there's iTind. This one's different again, right? It uses a temporary device. How does that function?
Yeah, iTind is quite unique. It involves placing a temporary device made of nitinol inside the prostate. Nitinol is this cool shape memory alloy.
Wow.
It's put in compressed, then it gently expands and applies pressure, kind of reshaping the prostate over several days, creating new channels for urine to flow through. Then you take it out.
So it's only in for a short time.
Exactly, usually just 5 to 7 days, then it's removed.
So what are the pros of using something temporary like that, and what's the trade-off?
Well, the benefits are pretty clear. Preserves sexual function, and there's no permanent implant left behind, no tissue actually removed, so no foreign body stays in you long term.
Right.
The main drawback is some guys find it uncomfortable while the device is actually in place, and retreatment is needed for maybe 6 to 12% of patients by 3 years. It's generally best for prostates in the 25 to 75 gram range, and again, typically not for those with a median lobe.
Okay, interesting. Let's talk about Optilume. This involves a balloon, I think, but with some kind of special coating.
That's right. Optilume uses a balloon to dilate or stretch open the prostate part of the urethra. But here's the twist. The balloon is coated with a drug called paclitaxel.
Paclitaxel.
Yeah.
Isn't that a chemotherapy drug?
It is, yeah. It's often used to prevent cell growth in cancer treatment. Here, it's a very low-dose coating on the balloon. The idea is that when the balloon expands, the drug gets transferred to the tissue and helps prevent the prostate cells from growing back and closing off that channel again. So it aims for a more lasting opening. It's pretty minimally invasive, and early results look promising.
I think I heard there's a specific warning with this one, though, especially for men thinking about starting a family.
Yes, exactly. That's important. Because of the paclitaxel, there are specific post-procedure guidelines. You need to use a condom for a month afterwards and avoid conception for 6 months. So that's a key consideration for some men. The data for Optilume is still, relatively new, but early studies are showing maybe 75 to 80% improvement at the 1-year mark. It's definitely a newer option offering a different approach.
Okay. Moving on to prostate artery embolization, or PAE.
Yeah.
This sounds quite different, like something an interventional radiologist would handle. It attacks the problem from a whole other angle.
It really does. This is performed by interventional radiologists, not urologists typically. They go in through blood vessels and essentially block the small arteries that supply blood to the prostate.
So you starve the tissue?
Exactly. The idea is to reduce blood flow, which causes the prostate to shrink over time. Recovery is generally quick, and it usually preserves sexual function quite well.
So what are the main trade-offs with PAE, especially when you compare it to the other procedures we've talked about?
Well, the main drawbacks are that it's generally considered less effective than direct surgical tissue removal, particularly when it comes to improving the actual force of urine flow.
Okay.
And the retreatment rates can be higher, maybe up to 25% at 5 years. It's interesting how PAE brings in a different medical specialty, though. For someone listening, maybe someone who isn't a great candidate for traditional surgery because of other health issues, this could sound like, a viable alternative.
Right, a potential option for them.
Yeah, it's often considered ideal for men with a very large prostates who might be poor surgical candidates otherwise.
Okay, last one in this minimally invasive group, aquablation. The name alone sounds very high-tech, very precise.
It certainly is. Aquablation uses a robotically controlled, high-pressure water jet-like, a very precise power washer to remove prostate tissue.
Wow.
It's guided by real-time ultrasound imaging, so the surgeon can map out exactly which tissue to remove with incredible accuracy. A huge benefit here is that it can work on prostates of basically any size, even those with more complex anatomy, like that median lobe we keep mentioning.
So, with a procedure that sounds so effective and, well, precise, what are the main things to weigh up, the potential downsides?
Okay, the primary risk to be aware of is about a 19% chance of retrograde ejaculation.
The semen going backwards.
Exactly. Semen goes into the bladder during orgasm instead of out. It's not harmful medically, but it's definitely a significant consideration for many men, especially if fertility is a concern. That 19% is higher than some of the other minimally invasive options we discussed.
Right.
However, aquablation boasts low blood transfusion rates and only about a 4% retreatment rate reported at 4 years, which is quite good. The main practical drawbacks are that it does require general anesthesia and it needs a specialized facility with the robotic equipment. So it's a bit more involved logistically than, say, an in-office procedure.
Okay, so these are the less invasive routes, often picked for, quicker recovery, better chance of preserving sexual function, using some really innovative techniques, steam, implants, even temporary devices. But what about when those maybe aren't enough? Or for more complex situations like really large prostates? That's when we start looking at the more established traditional surgical options.
Precisely. And the first one we really have to talk about here, the one that's been called the gold standard for BPH surgery for a long, long time, is TURP. That stands for transurethral resection of the prostate.
The gold standard. Okay. How does TURP actually work? And what kind of anesthesia are we talking about?
So TURP uses an instrument inserted through the urethra that has an electrified wire loop on the end. The surgeon uses this loop to basically shave away or resect the excess prostate tissue bit by bit, clearing the channel.
Kind of like scooping it out?
Sort of, yeah. It definitely requires either general or spinal anesthesia. You're not awake for it.
So what made it the gold standard for so long, especially if it's considered more invasive than those options we just covered? What are its enduring benefits?
Well, its main strength is the sheer volume of long-term data we have on it. We know it's very effective at relieving symptoms, and it's incredibly durable. The retreatment rate is really low, less than 10%, even after 10 years or more.
That's impressive durability.
It really is. That long track record of success is why it held that title. The risks, however, are notable. About a 6% risk of needing a blood transfusion, which is higher than many others.
Okay.
And nearly universal retrograde ejaculation. That's a big one. Plus, there's often a need for a catheter for a short time afterwards while things heal.
Right. So if we move beyond TURP, another set of established options that have really come into their own are the laser procedures. I know there are a few different types under that umbrella.
Yes, that's right. These include photovaporization, which many people know by the brand name green light.
Yeah, I've heard of green light.
And then there are the enucleation procedures, HOLEP, which is holmium laser enucleation of the prostate, and THULEP, using a thulium laser.
Okay, HOLEP and THULEP. What's the big advantage that lasers bring, especially maybe for guys on blood thinners?
That's a really key advantage. Because lasers use focused light energy, they can simultaneously cut and cauterize the tissue they seal blood vessels as they work.
Less bleeding.
Much less bleeding. That makes them generally safe options for men who can't stop taking blood thinners for surgery. They also tend to offer pretty rapid symptom relief.
How do they compare durability-wise and risk-wise, maybe against TURP?
Durability is quite good. Retreatment rates are generally in the 4 to 7% range at 5 to 10 years. And HoLEP and ThulEP, the enucleation types, often have the lowest rates, sometimes even better than TURP in the long run.
How?
The risks. Well, they can sometimes cause more irritative symptoms during the recovery period, like burning or urgency as things heal. With the enucleation procedures, HoLEP and ThulEP, there's maybe a 6 to 8% risk of transient incontinence, meaning temporary leakage, though it usually resolves. And again, like TURP, almost universal retrograde ejaculation is expected.
Okay. And finally, in this more traditional category, we have robotic simple prostatectomy. When does this option usually come up? It sounds like potentially the most invasive one we've discussed today.
It generally is the most invasive, yes. But it has specific indications. It's really reserved for men with very large prostates. Usually we're talking over 100 gram, sometimes even larger, significantly bigger than what most other procedures can handle effectively.
Okay, so for the really big ones.
Exactly. Or it's also used sometimes when the surgeon needs to treat other problems at the same time, like large bladder stones or a bladder diverticulum, which is like a pouch that forms in the bladder wall.
And how is it actually done? What are the main pros and cons?
It's done laparoscopically, meaning through several small incisions in the abdomen, not through the urethra. Surgeons often use robotic assistance for enhanced precision and better visualization during the procedure.
Right, the robot helps.
The big benefits are that it's highly effective for these very large glands, and actually blood loss is usually quite low because of the technique. The main drawbacks are, well, it is more invasive, involving those abdominal incisions. Recovery time is longer, maybe 2 to 3 weeks before you're back to light activity. And like TRP and the laser enucleations, it also results in universal retrograde ejaculation.
Wow, okay. That is quite a spectrum of options we've covered. It really underscores that point you made earlier. There's definitely no single right answer for everyone. So how does someone actually start to make the right choice for them from this incredibly diverse menu? How do you tailor it?
You're absolutely right. Personalized care is just critical here. It really boils down to connecting all these details back to your own specific priorities and your health situation. For instance, if preserving ejaculation is like top of your list,
Yeah, a big one for many.
then you'd naturally gravitate towards options like UroLift, Rezum, iTind, or maybe Optilume, as those have the lowest rates of that side effect.
Okay. And what if someone's main priority is, say, minimizing anesthesia or having the quickest possible recovery?
Right. Then those minimally invasive, often office-based procedures we talked about first, Rezum, UroLift, iTind, those would likely be preferred. They generally offer faster recovery and less need for deep anesthesia.
Makes sense.
If, on the other hand, you're really looking for the most durable, maybe a one-and-done kind of solution, especially if you have a significantly large prostate blocking things up,
You want it fixed for good.
then the traditional options like PERP, or especially HoLEP ThulEP, or even that robotic prostatectomy for the very large ones, they come more into focus because of their long-term effectiveness.
And what about guys who have other medical issues going on, like needing to stay on blood thinners?
Yeah, that's a key factor. For those folks with comorbidities, like not being able to safely stop blood thinners, the minimally invasive options often have an edge, or specifically the laser procedures like GreenLight or HoLEP, because of that lower bleeding risk we talked about.
Right, the cauterizing effect.
Exactly. And for complex anatomy, that tricky median lobe or just a really massive prostate, it's super important to understand that some procedures just might not be suitable. That makes getting a detailed evaluation from a urologist who's experienced with all these options really crucial.
This feels like where it all comes together. The final advice. This is where someone listening takes all this info and figures out the next step.
Yes, absolutely. And the single most crucial piece of advice is have an open, honest, detailed discussion with your urologist.
Not hold back.
No. Talk frankly about your symptom priorities, what bothers you the most. Talk about your desired recovery time, what risks are you comfortable accepting, and be very clear about your concerns regarding sexual side effects. These personal preferences are absolutely vital in guiding the decision. The best procedure is truly subjective. It's what's best for you.
And beyond having that crucial conversation, what else should someone keep firmly in mind when they're choosing their path forward?
This is really important. Make sure your chosen surgeon is experienced with the specific procedure you are considering.
Ah, experience matters.
Hugely. High operator volume, meaning a surgeon who does a lot of these specific procedures regularly, that strongly correlates with better outcomes and fewer complications. Don't ever hesitate to ask your surgeon, how many of these have you done? What are your typical results?
That's great practical advice.
It really makes a difference.
And with that, wow, we've really journeyed through the whole landscape, haven't we? The comprehensive range of surgical options for BPH, from those cutting-edge, minimally invasive techniques right through to the tried and true traditional approaches.
We really have. And with so many advanced solutions now available, it's kind of fascinating how the most sophisticated technology still boils down to the most human elements, your personal priorities and finding an experienced hand you trust. This deep dive, I think, really shows us that true cutting-edge care isn't just about what's technically possible, but about figuring out what's truly right for you.